thanks for having me be here to give you some updates on the data and research regarding the pandemic. As usual, I'll give you the update overall. May 21st, as of yesterday, May 21st, there are over 5 million people who were diagnosed with COVID-19 and about 320,000 deaths worldwide. In the United States, there are 1.6 million infections, and today I think it's up to 95,000 deaths. The good news is that the number of new infections and deaths have plateaued or declining slightly in the United States. The bad news is that I missed the last couple of meetings. The 21 days since I last updated you, the total number of infections and deaths have increased by 50%. There are still consistently over 20,000 new cases and 1,000 deaths in the US daily. There's a new report from the Kaiser Family Foundation that showed that in 18 states, a majority of COVID-19 deaths came from residents of long-term care facilities. So that's definitely a very high-risk group. One piece of information that might be interesting to us is that there's a large, what we call meta-analysis, which is a study of a bunch of studies of 11,000 COVID patients that show that people who smoke cigarettes with COVID, who get COVID, were at twice the chance of getting the disease or having the disease getting worse. We'll focus a little bit on minority communities. There's a lot more data coming out that emphasize that the burden of COVID-19 is disproportionately on minorities. In California, there is evidence that African Americans and Latinx age 18 to 49 are dying from COVID-19 at a rate 2.5 times that of their white counterparts. What's really shocking is that more than 20,000 African Americans have died from COVID-19 for a mortality rate of 50 per 100,000 people. This means that 1 out of every 2,000 African Americans have died from COVID-19 just in the last 3 months alone, which is a staggering statistic. The similar mortality rate for Latinx is 22.9, Asian 22.7, and whites at 20.7 per 100,000 people. The Navajo Nation in Arizona, New Mexico, and Utah now has the highest infection rate for a population, higher than that the state of New York. We know the Pacific Islanders have disparities in COVID-19. And our own Asian American Research Center on Health just published a recent research brief that shows a possible mortality disparity among Asian Americans in San Francisco. Along that line, I do want to give a shout out to a website put together by some of our UCSF students that address common COVID-19 myths in English, Spanish, and 5 other Asian languages. It's COVID19factcheck.com. In the largest study examining COVID-19 outcomes to date, the medical records of 17 million adults in the United Kingdom were analyzed to assess for factors associated with deaths from COVID-19. They had 5,683 deaths in the hospital, and as with many other studies, the death risk was associated with being male, being older, and having uncontrolled diabetes. Interestingly, being poor was also a risk factor from dying from COVID-19 in the UK. And additionally, being Black or Asian were also at higher risk of death compared to white Britons. I do want to, on the disparities angle, I do want to note that the US Congress House Ways and Means Committee is holding a virtual hearing on COVID-19 and people of color on May 27th. And that organizations can submit letters about this, and happy to send a link to that in the chat in a minute. One piece of good news is a study from New York that found almost everyone who had a documented infection upon recovery developed antibodies to it. However, it's not clear if these antibodies are protective from future infections. On the testing front, a group of infectious disease specialists reported that COVID-19 testing is quite disorganized, and they recommend better coordination at the national level. They do recommend that testing should be done for patients with symptoms, for what we call disease surveillance and contact tracing, and for monitoring of frontline workers like emergency responders and healthcare workers. People without symptoms in a high-risk group, such as long-term care facilities, should also be tested. But they do recommend against universal testing of people in the hospital, schools, or community-based testing. In terms of treatment, the big news is actually from today, a report from the Lancet, the journal Lancet, that show chloroquine and hydroxychloroquine is harmful. They look at 96,000 patients, COVID patients from 671 hospitals in 6 continents. And the bottom line was that patients on chloroquine alone or with another medication, or hydroxychloroquine alone or with another medication, were all more likely to die in the hospital than those who did not. This is the biggest but not the only study that shows harm from these drugs. And my recommendation is that no one with COVID should be on hydroxychloroquine or chloroquine. There are currently 8 potential COVID vaccines in development or being tested. This week, one vaccine manufacturer reported that in phase 1 trial with humans, its vaccines generated antibodies in some of the patients. However, because this went out as a corporate press release and not as a research report, we are unable to assess the validity of the data or what it means. I will finish this update with a concern about the quality of data we are getting from government agencies. The state of Florida fired one of its COVID-19 data scientists. According to the state, the reason was because the scientists were being disruptive and were insubordinate. According to the scientist, it was because the data and the way she was presenting it did not fit with the governor's narrative that it was fine to reopen the state. Perhaps not coincidentally, the number of new COVID cases in Florida yesterday was the highest it has been for 30 days. Several states, including Texas, Virginia, and Vermont, admitted that they were combining the number of tests done for diagnosis using the nasal swab and the antibody test done to document recovery using blood. They are 2 very different types of tests for different purposes. And this seems to me to be an attempt to inflate the number of COVID tests being done by the government. I will finish by saying that it is hard enough to collect, report, and analyze data on the pandemic that is timely and helpful for people and policymakers to plan. But if the data were being deliberately distorted, this makes it almost impossible. So we need to continue to ask for better data and data transparency. Thank you.
Thank you so much, Dr. Nguyen. Very complete briefing. So now we go into the topic of how this pandemic is affecting women. And I have the pleasure to introduce to you Dr. Beatrice Duncan, Policy Advisor, Rule of Law for United Nations Women, who will speak about a briefing that this organization put out regarding the impact of COVID-19 on women, and that we will send to you afterwards. Dr. Duncan, please go ahead.
Inviting UN women to this event. And I think I really admire the fact that there exists an organization such as yours that deals with issues of ethnic people. So this is fantastic. Now, before I proceed, I just want to let everybody know that just before this pandemic became global in nature, UN Women and women's organizations, national women's machineries around the world were about to celebrate 25 years of the existence of the Beijing Declaration and Platform for Action in New York. And this big event had to be canceled. And it was very unfortunate because we were going to actually review 25 years of this declaration. And it would have given the whole world a report card on women across several sectors. So it's a very big pity that the Commission on the Status of Women in March of this year had to be canceled because of COVID. And it was actually the first United Nations event to have been canceled in New York. Having said that, I would like to say that UN Women has been monitoring the event very closely. And as Pilar said, about 2 months ago, we issued a report on the impact of COVID-19 on women. And I would like to give you a few snapshots of what that report is talking about. In many ways, we know that COVID-19 is aggravating the existing situations of women in which we have found ourselves to be discriminated against across all sectors, be it in the health sector, employment sector, political sector, social sector, and cultural sector. So COVID-19 can be said to be a situation in which women's rights and the advances and progress made in women's rights is actually being set back in a very serious way. So let me give you some concrete examples. We know that about 2.73 women around the world are in lockdown situations in which they are in stay-at-home situations, in quarantine situations, or in curfew situations. This is relegating them to the household or to be in the same environment with their abusers. As a result, we have seen a threefold spike in the incidence of intimate partner violence or domestic violence. We are seeing situations in which women are being abused not only by their partners, but sometimes also by their adolescent children. So this is creating a situation of insecurity for women. And because the police force happens to be part of the frontline staff, women are not getting the protection they need from the police instantly. Therefore, in many countries, other ways and means are being devised to enable women to report violence. For example, in Spain, there is an innovation that allows women to go to the pharmacy to signal through either